This gentleman really needs no introduction within our academy. He's been practicing integrative or alternative integrative medicine since 1978. He's the former president of the American Academy of Ozonal Therapy and is vice president of the Society of Orthomolecular Health Medicine. He's written 2 books, one for professionals, the other for the lay public, on the concepts of ozone therapy. And he's the developer of the Prolozone injection therapy technique, utilizing ozone to regenerate damaged joints, herniated discs, tendons, soft tissue, and has revolutionized the practice of anti-aging and preventive medicine by developing a method to measure the relationship of mitochondrial function and oxygen utilization. He is widely considered to be the godfather of ozone therapy within this country and has been a guide and mentor to many members of this academy. All right, a man, like I said, who needs no real introduction, Dr. Frank Shallenberger.
All right, got it. Okay, thank you. Okay. Hey, good morning, everybody. Welcome to the start of a wonderful conference. And I just, I see you guys every now and then, and I just want to congratulate you and congratulate this academy for such an incredible job. You guys are just amazing. So thank you for having me here. All right, so for some of you, this is going to be one of those presentations where everything you thought was right is wrong. You ever been to one of those? Okay. So for others of you, you're going to start to understand why it is that cholesterol levels have absolutely nothing to do with the formation of plaque. Nothing to do. So that's what we're going to cover. I'm going to show you an abundance of evidence to prove that. And then the next logical question is, if cholesterol is not causing plaque, what the heck is? So we're going to dive into that. The evidence is fairly overwhelming that it's clotting, abnormal clotting, but it's not 100% proven. But I think you'll agree with me that that is the most likely tack to take. At any rate, all this nonsense, and I call it nonsense anyhow, about lowering cholesterol, measuring cholesterol, paying attention to cholesterol, I think after this presentation, at least I hope, you'll understand that that's all a waste of time. Okay, so what really causes heart disease? Let's see. So far. Okay, that's not doing it. Let's try this. Okay. Yeah. Okay, so, not a couple of years ago, a fella, and I list him right here, wrote an article that was published in Medical Hypothesis where he looked at 3 diseases and the history of these 3 diseases. They were macular degeneration, heart disease, and Alzheimer's disease. And the long and the short of it was he discovered that prior to 1920, those diseases did not exist. When we were eating nothing but animal meat, before processed foods, Alzheimer himself in 1880 described Alzheimer's disease as being a disease of the young and very rare. The disease we have now that we call Alzheimer's is a new disease. Essentially, we created it starting around the 1920s. William Osler is quoted in 1906, and he was the head of the Department of Medicine at Johns Hopkins University for 20 years. And he was quoted saying he had almost never seen a case of a heart attack. That was in 1906. And finally, when the author of this paper researched the literature for descriptions of macular degenerations, he couldn't find one ophthalmological text or article that described macular degeneration until it started appearing somewhere around the 1920s. So you might ask yourself, why? What the heck did we do to create these diseases? And I'm going to be focusing mostly on heart disease, but just keep that in mind. Prior to 1920, when there were virtually no processed foods, and the only fats anybody got in their diet, seriously, something like 98% of the fat in a diet back then was animal origin fat. No heart disease. So hopefully we'll learn a little bit why that might be. Okay. Darn it. First one worked. Let's see if I push on it. Let's see what happens. All right, I guess I'm running into a problem. Oh, is this thing on? Oh, it's on. Darn it. Guess I might need a little help up here. Nothing's changing the slides. Here's the clicker. It did it the first slide, which is interesting. And I don't mind using this if you can get it to do that. Oh, I see. Okay. So I can just hit the touchpad? Okay. It's working now? Okay. Okay, so basically, the points to cover are going to be basically two things. I'm going to try to convince you that cholesterol has nothing to do with the formation of plaque. I mean, literally nothing. I don't mean 99% or 1% to do. I mean 0%. And that being the case, I'm going to try to convince you that the real cause of plaque is abnormal clotting. So I want to point out this book, which is probably a book every single individual in the country, especially the cardiologist, should read. Because, most of the cardiologists, at least I've found, are just programmed by pharma. And there's also litigation involved. There's some liability involved. If they don't reduce cholesterol and their patient has a heart attack, they'll be sued because everybody knows that cholesterol is what causes heart attacks. Everybody knows this, except it's wrong. So this is a mind blower, and I hope you guys take a look at this. This was written by a Scottish cardiologist by the name of Kendrick. It's only got 240 references in there. This is a real scientific book. So this is where I'm getting probably a good 75% of the information I'm going to share with you. Okay, so we're going to look at some important studies that apparently nobody read. I personally think they were buried because these studies predominantly are back in the late 80s and the very early 90s when statins just came on the market, which are now, a $4 billion a year marketing device. So there's that a little bit to deal with. But these studies apparently nobody read. Okay, let's see if I can see that. So if I could get a whole version of this, but so it's pretty hard to see. So, I can move away from the podium. How about that? Okay, so this study came out in 2022, and it's looking at the association between low-density lipoprotein cholesterol, LDL, the bad guy, right, and relative and absolute effects of statin treatment. We've been programmed to think that statins actually reduce heart disease. This was published in 2022. And the quote is, they did this to assess the association between absolute reductions in LDL cholesterol with treatment with statin therapy and all-cause mortality. Does it actually work? Does it save lives? That's what they want to look at. So they, searched PubBase. They found PubMed. They found 22 placebo-controlled trials, and they looked at that. What they found, the absolute risk reduction for all-cause mortality was 0.8%. That's nothing. 1.3% reduction in deaths for myocardial infarction and 0.4% reduction in deaths for stroke. So what this means is, according to that data, in order to save the life of one person using a statin drug, you need to treat 125 people with a toxic medication for the rest of their lives to save one life. Now, I will maintain to you that if you have to treat 125 people with aspirin to make a headache better in one, it's not a very good drug. Not an effective drug. It also means in order to prevent a heart attack, with a statin drug, you got to treat 76 people for their entire lives with a toxic drug, with many side effects, which we'll cover. And finally, in order to prevent stroke with a statin drug, you need to treat 250 people in order to save the life of one person dying from a stroke. With a toxic drug, they take the rest of their lives. Now, who's going to think that that's good business? Who's going to think that that's good medicine? And this is a shocking thing that apparently nobody read. The conclusion is from the authors, a conclusive association between absolute reductions in LDL cholesterol levels and individual clinical outcomes never established. Didn't happen. Okay, this one's an older study now. This goes back to 2017. Most major heart attacks occur in people with normal cholesterol. Did you know that? So just because you have normal cholesterol obviously means nothing. They looked at 162 men and women, average age of 63 years, all of whom had a recent MRI. 647 were not on a statin. Their LDL levels were somewhere between 87 and 133. 44 patients were on a statin. Their LDL levels are basically the same. 39% of all patients who had an MI, 39% of them had normal LDL levels as determined by the third report of the National Cholesterol Education Program. And the lead author explained, heart disease is a multifactorial process. Now keep that in mind, because we're going to talk about what are the real factors involved here. He's pointing out to you, it's not about LDL, it's about other stuff. So we're going to talk about that. And factors other than cholesterol, like he mentioned smoking, high blood pressure, he leaves out lack of exercise, he leaves out lousy diet, he leaves out all the plant oils that came up in 1920, he leaves out the massive amounts of sugar that people started eating in the 1920s, he leaves out all the processed food that came up since the 1920s, he leaves diabetes out, he leaves heavy metals out, he leaves a lot of stuff out, but nonetheless, can raise your risk even if your cholesterol is normal. Basically, he's telling you, forget the cholesterol thing, deal with the real causes. Okay, there we go. All right. Magic somehow. Okay. Here's a double-blind study. Now this one is an older study. So here's a double-blind, randomized control study. 923 women and men, a big age bracket, 20 all the way up to late 90s, designed to test whether replacement of saturated fat with vegetable oil, because that's what happened in 1920. That's when Crisco came up. Crisco came up in 1920, and then all your processed vegetable oils came up at that time. So he's looking to see if you replaced all those plant oils with pure animal fat, i.e. prior to 1920, well, what happened? And what he concludes is available evidence from randomized control trials show that replacement of saturated fat in the diet with the linoleic acid, the polyunsaturated fats that are supposed to save the world, lowers serum cholesterol. They do, apparently. But it does not support the hypothesis this translates into any reduction in death rate. Okay, so these are not safe drugs. You know, if they were like vitamin C or something safe, who would complain? Okay, so you treat 100 people with a completely safe, inexpensive treatment in order to save one life. I could kind of buy that a little bit. These are not safe drugs. Those 250 people that you're going to treat for stroke. Now, I just had a patient come in 2 days ago. He had a stroke, goes to the ER. Guess what they put him on? A statin drug. They've got to treat 250 people like that in order to save the life of one. And these are toxic drugs. So rhabdomyolysis, it'll waste your muscles. That's a big problem for us, and I don't know if you guys know, but your muscle mass is a major determinant of your blood sugar levels and all kinds of other things which we can't get into. But it will destroy your muscles. It can induce thrombocytopenia. This is all published stuff. Hair loss, cutaneous neuropathy, hepatitis. How many of you guys know this? I don't think the cardiologists know this or appreciate it. Pancreatitis, renal failure, big time in renal failure. Diabetes, cognitive impairment, big time with cognitive impairment. Your brain needs HDL. And ED and decreased libido and premature aging. So they're not benign drugs that we're using here. I don't know how this thing works, but anyway. Okay, so what's in the plaque? Have you guys ever heard this? What's in the plaque? Has anybody bothered to look what's in the plaque? Yeah, that would be pretty smart. They bothered to do it back in 1991. What did they find? I'm going to show you two studies here. Basically, the studies are the same format. Researchers go into the hospital and do autopsies on people who have recently died from coronary artery disease, go in there, pull the plaque out, analyze it. What's in the plaque? That seems pretty darn smart. Okay, so that's what they're doing here. Here's what's in the plaque. They get some fibrous tissue. Most of it's fibrous tissue. You remember this now, because I'm going to come back when I talk about clots, because you're going to see it's what's in this plaque. What these guys found in the plaque is what's in a clot. Okay? Calcific deposits, we all know that. Pultaceous debris, that just refers to a mushy, proteinaceous fibrous material. And foam cells. Guess what? They didn't find any cholesterol. Zero, nada, not in there. Okay, so here's another study. This one also back in the old days, 1995. I think these studies must have been buried. Did the same thing. What's in the plaque? They found smooth muscle cells, macrophages, lymphocytes. They found some lipids in there, lipoprotein. Towards the end of this lecture, I'm going to show you that's what's in clots, by the way. Fibrinogen, that's in clots. Proteoglycans, collagen, that's in clots. Elastin and calcium. And again, no cholesterol in the plaque. There's no cholesterol in the plaque. Now I'm going to explain to you why it's impossible for cholesterol actually to form plaque, because it has to do with the layers of the artery. All right, let's go. Okay, so, skip that one. Okay, so the major things that have been brought about to make us believe that cholesterol causes plaque are basically three findings. One is fatty streaks in arteries. So we're going to address that issue. Another is that there are cholesterol crystals in the plaque. Not cholesterol, but cholesterol crystals in the plaque, which we'll talk about that. And finally is the whole idea of LDL, which I've already pretty much addressed. But we're going to hit those three topics and show why those are in error. Okay, so fatty streaks. These are fats found on the artery, on the surface of the artery, not underneath the endothelium. That's important. On the surface of the artery in just 3-year-old kids. And they go all the way up to 20-year-old kids. And the proponents of the cholesterol theory have always said, yeah, that's what starts the plaque off, even at an early age. Okay, so there's two articles I'm going to point to. This first one here was published by Velikan. And he concludes, among the 4 types of early atherosclerotic lesions investigated, that would be the fatty streak thing, only the fatty streaks did not show any direct conversion to a lesion of possible clinical significance. So he basically, Velikan, in 1983, blew this out of the water. Apparently, the authorities didn't pay much attention to that. Later on, in another proceeding, the results of the proceeding indicated that for many years it was widely believed that the fatty streaks were the precursors of fibrous plaques. However, there is now evidence from many different sources, including the work of the Velikans, that suggests that fatty streaks and fibrous plaques develop by a separate and independent pathway. So you can blow off the fatty streak thing. Amazingly, this was shot down in 1983. Amazingly. Just buried. Okay. Cholesterol crystals. What about cholesterol crystals? There are cholesterol crystals in plaques, but here's what you need to know. In order to get a cholesterol crystal, you have to have pure cholesterol. Cholesterol doesn't exist in the blood in its pure form. Okay? It exists tied to a lipoprotein. When it's esterified to a lipoprotein, it cannot crystallize out. Therefore, the cholesterol crystals in plaque can't come from the cholesterol in your bloodstream. Impossible. Where do they come from? What's a source of cholesterol, pure cholesterol, in the bloodstream? How about the red blood cell membranes? They're loaded with pure cholesterol. And so if you get red blood cells in there, which you'll see, that's what happens with a clot. You're going to end up with cholesterol crystals. So shooting down the cholesterol. So he just shot down the fatty streaks. Now he's just shut down the cholesterol crystal thing, because that's literally impossible. You think they didn't know that? No, they knew it. But it's literally impossible. So let's look at the LDL thing. Arteries consist of 3 layers. You guys probably know all this. You got your endothelium, that's the inner layer. Then you got your media, that's the medial layer. And then you have the externa, which is the outside layer. Plaques, get this is important. Plaques form under the endothelium, not on top. See, I always thought, and maybe some of you guys do too, that plaque forms kind of on the surface. You see these pictures where the cholesterol plaque is forming on the surface, inner surface of the artery. That is not true. It forms under the endothelium, under one of the layers. How does it get there? How does this supposed cholesterol even get there? You're going to find out it's impossible. The endothelium has incredibly tight junctions, and nothing, including LDL, can get through those junctions and penetrate that endothelium. But the next thing, so just remember that. The LDL can't get through there. It can't possibly form the plaque. It can't get through there. We're going to talk about how you do form plaque underneath there, and it's got to do with clotting. And one other thing I want to point out to you, that there's 2 lipoproteins in your blood. One of them you really want to look at. Actually, you want to look at both of them. You want to look at your LDL cholesterol, make sure it's not too low. I'm going to show you a study, because if it's too low, you won't live as long as if it were higher. So make sure your LDL is not too low. And number 2, check your lipoprotein A. Now, the difference between LDL and lipoprotein A is very simple. Lipoprotein A is a molecule that consists of LDL plus apolipoprotein. It's the same molecule. So you got your LDL plus you got an apolipoprotein attached to it. Now you got lipoprotein A. That's important. So remember that. Wherever you see apolipoprotein, that's from lipoprotein A, not from LDL. We'll come back to that. The lipoprotein in plaque consists of, there is lipoprotein in plaque, okay? But it consists of LDL plus apolipoprotein. It doesn't consist of just LDL. LDL plus apolipoprotein. So where's it coming from? Where's it got to come from? It can only come from lipoprotein A. So we're going to talk about that because lipoprotein A is big time involved in clotting. Amazing, huh? Okay. Try this method. Method doesn't work. This thing needs a little help, you guys. Go figure. I guess I need help. I don't know why it works and then doesn't work. Anyway, while he's doing that, I mean, the gist is you're starting to understand now the cholesterol's got nothing to do with this. I'm going to show you an article pretty soon now, a recently published article that indicates literally the higher your cholesterol, the longer you live. Past the age of 60, okay? There's an age-related thing right there. It's all about clotting. So if you want to prevent heart disease, guess what you don't do? You don't lower your cholesterol. Guess what you do? Do a whole bunch of things. But one of them is to deal with clotting. The other things are going to be, hey, but how about your blood sugar? How about your diet? And so forth. We're going to go with that? Okay, all right, thanks, man. All right. Okay, so here we go. So this is a little picture of how this thing works. So there's your endothelium right here. This is your media, and here's your externa. Look where the plaque is. See, I always thought it was coating the inside of the artery right in here because the pictures used to show that, right? And that's not true. It's underneath this endothelium. That's where the plaque is formed. How does LDL get in there? It can't. How does anything get in there? I'm going to show you in a second. It has to do with an injury. So we'll come back to this. Come back to this one. Okay, so if it's not LDL, what really causes plaque? Here's the scenario. Something damages the endothelium. Now, this happens all the time. Happens all the time. It's the body is set up to have something bad happen to it because it's going to fix it. That's where we were created. So all the time, our endothelium's getting damaged. Not to worry. We have a system that comes along and repairs the damage. So clots of problems are going to happen if, one, there's excessive damage occurring, or two, the ability to stop the damage and heal it is lacking. So those are the two kind of concepts we're going to look at. So something damages the endothelium. All this stuff that I'm going to show you right now is published data. We know, this is published, we know that this will damage the endothelium. Inflammation. Okay, inflammation damages the endothelium. Your CRP is high, you're at risk for damaging your endothelium more than you ordinarily would. Plant seed oils. Those are all oils in your diet, whether you're pouring the oil in your food or you're buying food without those oils in there. All oils except olive oil, coconut oil, and avocado oil. Every other oil, the safflowers, the sunflowers, the peanuts, the whole package, they will damage your endothelium. Oxidant stress damages your endothelium. Hyperglycemia, nitric oxide deficiency. Air pollution is published to damage your endothelium. Scurvy and other nutritional diseases. And you might think, well, there's no scurvy going around. Well, maybe not in the obvious sense of the old scurvy, but there is subclinical scurvy going on for sure. Tobacco, hypertension, oxidized LDL. So I'll talk a little bit about a special form of LDL called oxidized. That's when the LDL molecule is actually oxidized. It can start damaging the endothelium. It won't create plaque, but it starts the initial damage. Any virus can damage the endothelium. We saw that recently. Bacteria, especially the bacteria that come from periodontal disease, can damage the endothelium. Stress can do it, elevated homocysteine, and PPIs that they use for GERD and such. All those things can damage the endothelium. So if you want, as you'll see here before you're done, if you want to prevent heart disease, you start thinking that way. Okay? So what happens when it gets damaged, its platelets are drawn to that area to stop the damage, to stop the bleeding. We're in the bloodstream here. We're talking about bleeding. So when you damage that endothelium, there's bleeding, blood starts coursing past the endothelium into that media section there. But you stop the blood flow. Platelets are abundant in the bloodstream. They instantaneously stop that bleeding. And they combine with our friend lipoprotein A, plasminogen, and fibrinogen. Notice that this and that are both in plaque. In fact, the majority of plaque is the fibrinogen. You form and stop the bleeding. Okay, fine, great. The fibrinogen is then converted into fibrin, which binds the clot up. I'll show you a little picture in a sec. And then what happens is, so you got your plug in there, it's stopping the bleeding, it's starting the healing process. Stuff has gone past the endothelium, in between the endothelium and the media. But that's stopped now because the platelets have plugged all that up. And in that stuff is fibrinogen and lipoprotein A and some plasminogen. And then what instantaneously comes along is these things called endothelial progenitor cells, which are kind of like stem cells. They're circulating in your blood all the time. And the older you get, the fewer you have. Certain diseases and conditions cause you to have fewer. But they instantaneously rebuild that endothelium line. Think of it. You cannot have that endothelial line broken down very long. It can't be more than a few seconds, or everything would blow up big time. So instantaneously, these endothelial progenitor cells come back and replace the damaged endothelial cells. Now the clot, where is it? It's now between the endothelium and the media. That's how the plaque gets there, through this process. Plasminogen activating factor in the media, that goes in there, by the way, the plasminogen activates in the bloodstream, converts the plasminogen to plasmin, and then plasmin ultimately breaks down the clot. And that's the end of it. You got to damage the endothelium, platelets come along, stop the bleeding. You got plasmin getting converted by from plasminogen, dissolving the clot. Everything's healed, back to normal. Happening all the time right now as we sit here. Now, one thing I want you to notice is that this plasminogen factor goes to plasmin. Guess what blocks that? There's something that blocks that. It's called LPA. Lipoprotein A blocks that. It's a competitive mechanism. The LPA has a much longer affinity for plasminogen and so it doesn't convert to plasmin. Finally here, endothelial progenitor cells also turn into macrophages. That's how the macrophages got in there, okay? Between the endothelium and the media, which then can clean up any residual debris. So far we're accounting for all the stuff that's in plaque. That's just a little picture of it. There's your blood vessel. Here's the break in the endothelium. That's all that stuff dumping in. Eventually you form a clot, but notice it's underneath the endothelium. Well, that picture doesn't really show it. It should be out here, but anyway. That's important to understand that it's in between the endothelium and the media. So what's in a clot? You got your macrophages. They call them foam cells. Lymphocytes, LPA, fibrinogen, calcium, RBCs, that's where you get the cholesterol crystals. Fibrous tissue, which is all that pultaceous debris that they reported back in 1991. That's exactly what's found in plaque. Huh, isn't that interesting? No cholesterol in there, but there's all this other stuff in there. So, all the factors that damage the endothelium, all that stuff we just named, okay? That's going to encourage this to happen. Also, if you happen to have an elevated fibrinogen, that's going to dump more fibrinogen into this area, which is going to make it harder to break down the plaque. If you have a disease or a condition called Williams factor, that contributes to the breakdown of the endothelium. Dehydration can contribute to it, and NSAIDs, and that's why they took that Baycol or something off the market and that's where we learned that the NSAIDs and the COX-2 inhibitors can damage the endothelium. So stay away from those things very often. Okay, so as soon as the endothelium is damaged, the clot forms to repair the damage. As soon as the clot is formed, endothelial progenitor cells immediately replace the damaged endothelial cells, trapping the clot between the endothelium and the media. In this article, the researchers said endothelial progenitor cells move towards injured endothelium or inflamed tissues and incorporate into foci of neovascularization, thereby improving the blood flow and the tissue repair, basically a repair mechanism. Patients with cardiovascular disease have been shown to exhibit reduced endothelial progenitor cells number and function. So you might want to ask yourself, well, what can I do to make sure that my EPCs are not reduced in function and number? Because that is a big problem. If those endothelial cells don't come along and instantaneously repair the endothelium, this plaquing thing keeps piling on. And instead of having a little old plaque that needs to be dissolved, you're going to have a much bigger plaque that needs to be dissolved, I should say clot. And ultimately, that clot's going to turn into a plaque. Okay, so what else besides aging, which it does, reduces EPC number or function? Look at that. This is all published stuff. I didn't make it up. Diabetes, chronic kidney disease, steroids, and nitric oxide deficiency. Well, I think we can all relate to, that is described as risk factors for cardiovascular disease. Now we're having a better sense for why, so we can move on from that one. Okay, so finally, how does a clot turn into plaque? So now we've got this clot in between the endothelium and the media, and we're supposed to have the plasmin go in and dissolve the clot via enzymes, by the way. It induces certain enzymes. So we'll talk a little bit about an enzyme called nattokinase and one called lumbrokinase, which can be used to treat and prevent heart disease. But you're supposed to have that enzyme anyway. But again, it comes from the plasmin. But again, the plasminogen that's going to be converted to plasmin gets tied up with LPA. So you want to check your LPA levels. And let me just digress for a second. LPA is not treatable, okay? So that's why pharma hasn't, told you about it. That's why you don't maybe know about LPA, because they don't have a drug. There's nothing. I don't know any way to lower LPA. I've studied a lot, no way to lower it. It's a genetic thing. You just make LPA, sorry. But I'll tell you what, if you get a family history, your patient comes in and says, yeah, my mom and pop had, or one of them had, developed a heart attack at a young age. You check that person's LPA, it's probably going to be high. So that's one of the reasons. So check your LPA. Make sure it's at least below 50, very least below 50. Super low is great, but guess what? If it's high, you can't do anything about it. You can't do a thing about it. But what you can do is bypass it. So you can say, well, if it's high, that means I won't get the plasmin, I won't be able to dissolve the clot. So how do I get around that? I take aspirin and nattokinase or levokinase. So that's the treatment. Well, maybe we'll address this a little bit later on, but that's the treatment here. But check your LPA. If there's increased risk of endothelial damage resulting in excessive clot formation, that's one of the things that is going to cause that clot eventually to turn into plaque. The other thing I didn't mention is that the cholesterol theory implies that you've got this LDL cholesterol slowly on the surface of the artery, and over time it just layers on and layers on and layers on, and that's not actually what happens at all. That's what happens with a clot. That's exactly what happens with a clot. So if that clot is a little bit and you can't dissolve it for whatever reason, it'll start building on itself and getting bigger and bigger and bigger over time. The blood clot formed is bigger or more difficult to break down. That's going to make it harder to break down. If you have elevated fibrinogen, that's going to make a bigger clot. And the repair systems are impaired in some way, and typically that's an LPA type of phenomenon. Okay, so what are we going to learn out of all this? How do we prevent plaque? A patient comes in to see me. They got this strong family history of heart disease. What am I going to check? What kind of stuff am I going to check on them? Well, I'm going to check their oxidized LDL. Okay, that's LDL that's been oxidized. So when you get a total LDL on somebody, you're getting the reduced LDL plus the oxidized LDL. It's the oxidized LDL that is the problem, not the reduced. So forget looking at cholesterol, total levels of cholesterol, but you labs are now checking oxidized LDL. The oxidized LDL is high. Just remember, that's a factor that's treatable. We'll talk about it, but that's a factor that's treatable that can damage endothelium. Lipoproteinase, we talked about that. The fibrinogen's high. There's stuff you can do about that, but these are all the things you ought to check, okay? D-dimer levels to see if there's an continuous clotting going on. Blood pressure, of course. Blood pressure is very important. You've got to keep that down. Ferritin, I won't get in a long discussion about ferritin, but that's excessive iron. Exceedingly common. They say, 15, 20% of the population? I don't know. It's closer to 50, I think. But check your ferritin level. Now, keep in mind, for a healthy woman, ferritin wants to be between 20 and 40. For a healthy man, between 40 and 70. All the labs take it up now, up to like 200. They used to take it up to 400. No, you want your ferritin down to be below 100. Want it to be below, because that can damage endothelium. CRP, the inflammation marker, that can damage endothelium. Your blood sugar, so check your A1C. You might want to check for lead. Lead is a known endothelial substance that will damage endothelium. Homocysteine will damage endothelium, so it's a good marker. Look at your homocysteine. And check your omega index, your 6-3 index. You want to have no more than 5 times as much omega-6 than omega-5. So you want to look at that index. It's got to be less than 5. So those are the things. Okay, notice I'm not checking cholesterol. Not interested in cholesterol, because that's got nothing to do, as we know, with heart disease. But these factors do. And my cardiology friends don't typically check any of this. They might check LPA. Occasionally I'll see them check LPA, but they don't check A1C. What they do is check cholesterol and give you a flippin' drug that you have to take for the rest of your life, that in But the odds are really great, will do you absolutely no good at all, and is very toxic. But that's the kind of stuff you want to check. So, remember that initial slide, and the author said, you know what, LDL doesn't have much to do with absolute reduction in risk of death, but all these other things do, and I think he mentioned smoking, and I don't know, I forget the other thing he mentioned, but there's all this stuff he didn't mention, okay? So regular aerobic exercise. You've got to be aerobically fit. That produces nitric oxide, which repairs the endothelium. The two are one. It also repairs what's called the glycocalyx. And if you haven't heard of glycocalyx, when you've got nothing else to do, go look up glycocalyx. That's the kind of the surface of the endothelium, which is very contingent upon nitric oxide and very contingent upon your diet. And you need that glycocalyx to protect the endothelium from that damage we just talked about. So if they have a high oxidized LDL, pomegranate juice, about 4 ounces a day, can be very effective. They found pomegranate pomelo extract, which is a pill in case you don't want to drink the juice for whatever reason. Vitamin E is pretty good. Lipoprotein and garlic, all of those are pretty good at lowering that oxidized LDL level. I've had good luck doing those. If they have a high LPA, remember you can't lower it, but you can scoot around it with aspirin and nattokinase or lumbrokinase. Those two, in case you don't know, are, those are enzymes that dissolve clots. Fibrinogen, if they have a high fibrinogen levels, not too terribly common, but I check it anyway. That's a person automatically on nattokinase or lumbrokinase. Got to get the blood pressure right. How do you do that? Well, regular aerobic exercise is excellent. You might need blood pressure pills. I'll give you that. But try the beet juice, try the nitric oxide stimulants, the L-arginine, and so forth and so on, and see if you can't get the blood pressure better that way. And again, I mentioned the ferritin. The actual really good levels are that. If you have a level over this, donate blood. Simple, easy to do. Just donate blood, help you and help somebody else. Okay, more. Inflammation, periodontitis. Check those gums. I always check gums on my patient. See how they are. It's not infrequent to see some problems in there in patients with a history of cardiovascular issues. But so clean up that. By the way, if you don't know about it, probably you guys do, but ozone on the gums will clear it up in 10, 12 days. Curcumin and boswellia and all this sort of anti-inflammatory sorts of herbs can help. Again, I mentioned this, avoid all fats and oils. Remember, before these oils came on the market, no heart disease, essentially none. No macular degeneration, no Alzheimer's. So I think they're a big problem. So avoid all fats and oils except animal fat, except olive oil, coconut oil, and avocado oil. Those are legit, those are okay, they seem to be just fine. And check that omega index. Make sure that the ratio of 6 to 3 is less than 5. Most people don't have that ratio. So there's two ways you're going to deal with that ratio. One is decrease the 6, i.e. get rid of these oils. And they're hidden in everything, folks. When I learned about this, I go into my pantry, and I'm looking at all the stuff in my pantry. Anything that's got an ingredients label, check it out. It's got those oils in there. Now, if any of you guys ever make bread, you don't put oil in bread, but they do. Why do they put that oil in there? It's one of the bad oils. Anyway, just check the labels on everything and make sure that omega index gets normalized. Reduce your carbohydrate intake if you have to. Get that A1C down. And get that insulin wants to be below 10. Not a lot of doctors, I find, even the endocrinologists, don't always check insulin. Check the insulin level. Avoid the NSAIDs and the PPIs. If you want to do them every now and then, that's not a problem, but the continuous use is a problem. Chelation therapy, the patient asked me the other day, how does chelation work? And I had to say, you know what, I'm not sure. I know it has something to do with removing lead. It might mobilize calcium. I know it changes the ferric to ferrous oxide ratio, but I don't really know how it works. But I do know what it stimulates a good repair mechanism on the endothelium. That's for sure. And I can keep that homocysteine level less than 10. You can do that with folate, B12, B6, and trimethylglycine. It's just a different approach to treating heart disease. And so I hope that you guys will, if you're on statins, I hope you get off them. I know it's a little freaky. I have people that have had a heart attack or had bypass surgery and on the statin drug, and their LDL is alarmingly low. And I tell them, listen, you got to, but they've been so programmed. We've been seriously programmed. Oh my goodness, my LDL is high. I can just see it clogging up all my arteries. You hear that all the time. Doesn't happen. But a lot of times it's really hard to talk these people out of it. And I'll give them this kind of evidence, and it's just so hard. But if anyone you guys is on statins, I hope you take this seriously and look into it. And buy that book, Buy The Clot Thickens, and you'll learn the kind of stuff that I've learned. I always knew, just statistically, for decades I've known, just statistically looking at the numbers, that cholesterol probably had nothing to do with heart disease. But now I didn't know what did. I didn't know what caused the plaque, and that book is what turned me on to this. So that's where I learned this stuff. So if you want to take a deeper dive, go ahead and get that book, and I'm going to give you a little plug for the AAO, and maybe you can join us in Orlando this May, and thank you very much for letting me be here.
All right.
Do I have any time for questions? Or?
You're way ahead of schedule. You got us right back on time, yeah?
Okay, all right.
I'm not going to complain at all. We will have a speakers forum. You are going to be here for the speakers forum, yes?
That's this afternoon.
This afternoon, yes.
Yeah, yeah.
Okay, so if you have questions during the course of today's speakers, make sure you jot them down. The forum speaker will be at 5 p.m. today once everything's all said and done. Okay, you can ask questions to all of our presenters at that time.